Judy Garber, who's actually the president of the AACR, among many other things from Dana-Farber.
I'm not the president yet.
Not yet?
Next year.
Okay.
Next year. Well, I think there were a lot of questions in that question. But certainly one of the problems that is part of treating breast cancer and of preventing breast cancer, especially in very high-risk women, is that we make women menopausal very early. And we have to then help them struggle through the problems of hot flashes, which I personally won't minimize myself at this stage. But that they have many years of menopause symptoms, not only hot flashes, but others. And the challenge of how really to maintain quality of life despite all of these issues is not small. For women who've chosen surgical approaches where they've not only removed the ovaries to get rid of the risk of a disease that we can't detect and don't treat very successfully yet, and then also to reduce breast cancer risk, I personally am more comfortable giving hormone replacement because they've removed the organ that we're most worried about. Susan, I hope you'd agree. Right. So the question about do you give hormones in women who have not chosen to have their breasts removed? And the data from Susan's institution, with collaboration from probably half the people up here, shows that so far that's a safe thing to do too, at least temporarily, and then to try to reproduce a menopause that's more like a biologic menopause, which stutters gradually over time rather than happening on one day when surgery does. It's much more complicated than we make it sound when we try to find an approach that can make a difference in treatment, where you just, we all have to put up with some of the side effects and try to modulate them over time.
Well, what about, what I think is in this question as well is the role of topical low-dose intravaginal estrogens, E-string and so forth?
I'm Susan Domchick from the University of Pennsylvania, and people are encouraging me to stand up. Just BRCA1 and 2 mutation carriers are a unique population where the risks and benefits need to be carefully considered, and the fact of the matter is that early oophorectomy can do a lot of bad things to women, including cardiovascular issues and bone health, and in non-cancer patients we have to weigh things a little differently than in cancer patients. So I think that it is important that we sometimes lump everybody together, but we do have to think about people who have their ovaries removed, as Judy said, to prevent a cancer that we can't detect, and have not gone through their natural life of estrogen and then taken more, compared to someone who prematurely went through menopause for a different reason. So, and it does get at the hysterectomy question, which your doctor can further address, but yes, that might be a reason to consider hysterectomy in terms of which hormone you take. But to add, for Cliff, just because I'm now standing, topical estrogens, I think most of us in the room, I would say, don't have major issues with S-string, which is a vaginal estrogen ring, or topical estrogens related to severe vaginal dryness in our cancer patients, although women on aromatase inhibitors, I might punt back to someone else about how you feel about that.
So we're actually studying this right now. We have a prospective trial testing the systemic absorption of a very low-dose intravaginal estrogen for women on aromatase inhibitors, just maybe enough to alleviate the acute local symptom of vaginal dryness, but we're hoping not enough to do anything meaningful in terms of systemic exposure. So we will have more information about this in the years to come. Others have tried this. We're not the first, but others have tried it in relatively small numbers of patients, so we're pushing forward with this. Anna Marie, do you have a comment?
Stand up.
Start, speak up. So you're telling us everything's off the market today? Here you go.
Anna Maria Storniola from Indiana University. Vagifem is off the market at the 25 microgram dose, but the reason it's off the market at that dose is it's now on the market at a lower dose at 10 micrograms. So it is available, and the reason for that is it's just as effective at the lower dose. I'm not addressing the absorption issue, but it's just as effective at the lower dose.
And that's the low dose is what we're studying specifically. So we're going to have answers to this, at least in part. Okay, so.